Thank you so much for having me. And today what we're going to talk about is which EGA will save the day in cardiac arrest. Now, extraglottic airways have become more and more commonplace in the pre-hospital arena when it comes to cardiac arrest management. Now, traditionally, pre-hospital providers have always used the endotracheal tube. And this is really a huge source of contention, whether SGAs or EGAs or the endotracheal tube should be used in the management of cardiac arrest in the pre-hospital field. Now, there's been no demonstrated evidence that supports one or the other in terms of survival. They're very, very close. But there are a number of benefits when it comes to SGAs. The first being that all of these SGAs that we'll talk about are blindly inserted. Now, since these devices are blindly inserted, it makes them much faster and easier to place in the field. It also requires far less proficiency as well as less training. And finally, it allows for more focus on high quality CPR. It also decreases the cognitive workload of the provider so they can focus on other tasks. Now, what we'll discuss are the three most common types of SGAs that you'll see in the field or the emergency department coming from the field. Now, there's a number of different SGAs on the market, so this is not an all-encompassing list, but these are probably the three that you'll most commonly see. Now, the first one is the combi tube, and this is an infraglottic airway. It's passed typically directly into the esophagus, and we'll talk more about the combi tube here in a second. The second being the king airway, and that's a retroglottic airway, and it passes into, again, the upper esophagus. And last, the iGel, and this is a supraglottic airway that sits around the epiglottis. Now, the first one we'll talk about is the combi tube. And the combi tube is not as common as it once was. And as we'll talk about, that's a good thing. But this is something that reemerges its ugly head every once in a while and is still alive in some parts of the country. Now, this is a blindly inserted dual lumen airway that's been around since the late 80s. And it comes in two different sizes, and it is not available for the pediatric population. Now, when we look at this dual lumen combi tube, it has two cuffs as well. Now, the cuffs are inflated with 12 and 85 mLs of air, so a large volume of air. Now, the shorter white port is the distal lumen. Now, this opens just to the side of the beveled end of that distal end of the tube. We also have the proximal lumen, which is our blue lumen. Now, when ventilated through this port, it goes through the pharyngeal perforations. Now, with a combi tube, the thought is that it's going to be placed in the esophagus, and that's where it's supposed to go. Most placements will end up in the esophagus, so you'll ventilate through that proximal lumen. Now, if for some reason you happen to end up in the trachea, this is when you ventilate through that distal lumen. And that distal lumen acts just like a standard endotracheal tube. And you inflate both balloons. But with having two different ports, it kind of makes it complicated. And it makes a lot for the provider to think about in terms of a high stressful situation. Now, how this works is when you ventilate through that larger blue proximal tube or longer blue proximal tube, the air is going to come out of these perforations. And in the distal tube, number 2 tube or the white tube, it acts as an endotracheal tube. Now, the next tube we'll talk about is the king airway. And the King airway is probably one of the most common pre-hospital backup airways that you may encounter. Now, this tube again is placed in the esophagus, and it is only one port, as well as two balloons that are inflated through one syringe port. Now, the King airway has a number of benefits. Again, like the combi tube, it's blindly inserted. And with it being blindly inserted, you only need to inflate one cuff. And by inflating that one port, it inflates both cuffs. Now, this also takes a fairly large amount of air, but there's a number of different sizes when it comes to the King, which makes it very attractive for pre-hospital providers, where they have pediatric tubes all the way to adult. Now, when we look at the King airway, the color of the top port is the size. The King airway also has a gastric axis lumen, so you're able to decompress the stomach. It also has teeth markings to ensure that it is inserted to the proper depth. Again, when this is inflated, it inflates both the proximal cuff as well as the distal cuff. And ventilation occurs through those ventilatory openings that are going to sit right above the pharyngeal opening, or the area of the pharyngeal opening. As you can see, they come in a number of different sizes. Now, when we're talking about these sizes, it's important to know that 0, 1, 2, and 2.5 are based on weight, where 3, 4, and 5 are based on height. Now, the next is the eye gel. And the eye gel is a non-inflated soft cuff that forms an anatomical mold to fit over the laryngeal opening. Now, when we look at this tube, it's very beneficial because, again, it's blindly inserted. There's nothing that needs to be inflated, and after it's inserted, you can easily start ventilating the patient. And just like the King, it comes in a number of different sizes. As we look here, we can see that the size is marked on the top of the tube. Right below the size, it also tells you the weights for that specific size. Now, what's important to know about the King airway is the sizing is based on ideal body weight. The eye gel also offers the ability of a gastric channel to decompress the stomach. And it also has that position guide to show that you're in the proper place. Now, one of the big differences with the eye gel compared to the King or the combi tube is it has a much wider appearance. Now, this wider appearance is so that the tube doesn't twist and dislodge. Now, the eye gel also has a gastric opening, or an epiglottic rest above that gastric opening. The epiglottic rest is so the epiglottis does not fold down during insertion and cause a obstruction by the epiglottis. Now, sizing again is based on ideal body weight, which is very, very important when we talk about insertion. It's also available in pediatric sizes, which is making this tube very attractive for pre-hospital providers, as you can cover all age ranges. The only difference with the smallest tube of the eye gel is it does not have a gastric opening. All of the other sizes are suitable for a gastric opening. It also makes tube exchange of pulling out the eye gel after placing a bougie much easier to place a traditional endotracheal tube. Now, if you ask for my 2 cents, having used all of these different tubes in the field, I would say the most appealing is the eye gel for a number of reasons. The eye gel is very simple to insert. You just insert it and begin ventilating. And if it's situated appropriately, there's no issues. You don't have to worry about inflating a cuff or inflating multiple cuffs, or like with the combi tube, ventilating through different ports. Now, with all of these tubes, it's imperative that we use capnography to ensure that we're appropriately ventilating these patients. And if ventilation and oxygenation are occurring, there's no need to immediately replace a subglottic airway device. So in closing, just be familiar with the different SGAs. You may see a number of different SGAs, even though you're only familiar with one. Capnography is of utmost importance. And remember, with effective ventilation and oxygenation, there's no need to immediately replace the airway. Thank you so much. I really appreciate it. If you have any questions, please let me know.